Io sono Vittorio Grazioli, medico, amministratore delegato di Tomalab. Vi ringrazio di aver partecipato al primo di questa serie di eventi che abbiamo chiamato, diciamo, appunto Question Time, perché non vogliono essere il solito convegno e non vogliamo propinare, diciamo così, lezioni ex cattedra, ma devono essere l'occasione per i colleghi per porre quelle domande che magari non hanno mai potuto porre a chi è veramente esperto e titolato per rispondere. E oggi appunto avremo qui fisicamente e anche collegate dagli Stati Uniti le persone alle quali potete rivolgere le vostre domande riguardo SIGNATERA. A questo punto io passerei la parola al professor Bulfamante, che fa parte di questo board.
Grazie. Sono molto contento di questo evento perché è il primo evento dopo l'arrivo dell'università a Tomalab che fa iniziare un'avventura che vuole affiancare alla grossa esperienza in biologia molecolare, in patologia molecolare, anche l'esperienza classicamente dell'anatomopatologo, che è un po' un trade union tra il test di laboratorio e la clinica. E pertanto penso che questa sia una delle prime iniziative che poi anche insieme alla scuola di specializzazione di anatomia patologica dell'Università di Milano avremo modo di organizzare proprio per creare un discorso, per creare un'abitudine, una confidenza tra quello che è visto come il mondo del laboratorio, che non può essere soltanto un test a sé stante, ma deve andare a connettersi direttamente con il mondo della clinica, e penso che proprio l'anatomia patologica in questo faccia il suo mestiere, nel collegare due aspetti che possono sembrare lontani ma che invece devono assolutamente ricongiungersi nell'interesse del paziente. Con questo passo la parola all'oncologo.
Grazie infinite al professor Bulfamante per la sua introduzione. Ovviamente grazie a Vittorio Grazioli per l'ospitalità e per aver voluto promuovere un incontro su un tema che da sempre è estremamente vicino all'interesse degli oncologi. Sappiamo come nelle patologie emolinfoproliferative la valutazione della malattia minima residua giochi un ruolo fondamentale nella definizione del percorso terapeutico del paziente, di quel patient journey di cui tutti amiamo parlare, trovando oggi grande difficoltà nella gestione dei tumori solidi, nel concretizzarlo in iniziative cliniche pratiche da attuare al letto del paziente. Quindi sicuramente i primi lavori che sono stati pubblicati utilizzando SIGNATERA, e oggi vedremo l'esempio del cancro del coloretto metastatico, ma sicuramente ci sono molte altre patologie nelle quali SIGNATERA ha dimostrato con grande efficacia ed efficienza la possibilità di definire la persistenza di una malattia minima residua determinata dalla presenza di alcune mutazioni. Poi, come ascolteremo dalla presentazione del dottor Dani, anche una sorta di firma di quello che è la probabilità che ci siano ancora malattia nell'organismo del nostro paziente, rappresenta in effetti un progresso estremamente importante. Una strada che inizia con SIGNATERA, perché ovviamente a fianco dei lavori già pubblicati e delle molte iniziative di studi accademici multicentrici condotti negli Stati Uniti, in Europa e in molte altre parti del mondo, vedrà anche il nostro paese impegnato in percorsi di affiancamento di quella che oggi è una straordinaria opportunità complessità dal punto di vista tecnologico, ma che merita proprio per questo una maggiore sostanza nella definizione del patient journey, appunto. Quindi darei, senza sottrarre tempo alla discussione dopo le due presentazioni, la parola al dottor Ahmed Dani sulle basi molecolari di Signatera. Prego, dottor Dani.
Grazie. Hello, everyone, and it's a pleasure to be here today with everyone. And thank you to Thoma Labs and everyone to set this up. I'm going to try to speak as slowly as possible, so if you have any questions, please interrupt me. But the purpose of my introduction really is to introduce to you SIGNATERA and the technology of SIGNATERA within the actual product called SIGNATERA. A little bit of my background: I am a medical doctor by trade. I did my training in general surgery and transplant oncology, so a lot of that was the hepatocellular carcinoma space and then the pancreas space. And today I will be joined by one of my great colleagues, Dr. Bota, who will also be speaking as well. So we can go next slide, please. So to introduce SIGNATERA to everyone, right, we're not new to this space of diagnostics. In fact, we've been around since 2009. And you can see here we have a variety of products on the oncology section, the women's health, which of course there's a lot of people here that are very used to, and then the organ health space. And then we also launched, beginning of this year, our early detection business unit as well. So that is something to kind of look forward to. But specifically today, we're going to talk about SIGNATERA. Next slide, please. And of course, with over 5 to 7 million tests performed and over 11 years of continued innovation, we continue to kind of strive in this field. In fact, we took our expertise from our women's health and we really applied it to the oncological and organ transplant sector. And we have a product that is called SIGNATERA. And really, it's to assess, the scope of practice is to really assess the molecular residual disease status of patients. It's really to understand and surveillance for early recurrence for these patients, and to understand if these patients under immunotherapy or chemotherapy are actually responding to treatment. We also additionally offer Altera and Empower, which is our hereditary cancer test and our comprehensive genomic profiling test. Next slide, please. And if you look at the clinical kind of context of how patients' course disease is, you can see here that in the yellow, this is where the scope of practice of SIGNATERA really is. You can use it in the neoadjuvant setting. You can use it post-surgically in the adjuvant setting. You can use it for surveillance, and then of course in the metastatic relapse setting. What SIGNATERA is not, and it's an important distinction, it is not the early detection asymptomatic healthy patients. We will have something coming out, but for SIGNATERA purposes, it is not. It is the molecular residual disease status. Next slide, please. And so the question really becomes, what is our test and how do we use this test and why is it so different from other diagnostics out there? And first and foremost, we are a tumor-informed company, such that we require a tumor tissue, and it's a one-time tumor tissue, and the tumor tissue can be either a surgical or biopsy specimen, fresh, or it could actually be biobanked, and we can actually use the specimen from an FFPE specimen to design this assay. So once we take this tumor tissue, we have a normal control blood, and we match it, and it undergoes whole exome sequencing. And when we undergo whole exome sequencing, we pick and select 16 clonal variants. So this is a very important distinction because we are selecting these variants such that they are passenger mutations and not driver mutations. That means that they're not hotspot mutations like EGFR or VEGFR. These clonal mutations are very tumor specific and patient specific, such that as the tumor kind of evolves and it grows, we're able to pick up the signal on shot all the time. And so even when you have treatment with patients, we're not going to be losing signal because we can track these 16 clonal variants every time that the tumor kind of evolves and becomes more heterogeneous. It's important because a lot of diagnostics out there use kind of a library panel in which they conduct their studies or in their assay. So it's an important distinction. And once we use 16, 16 is used because through kind of trial and error, we've understood that if you go above 16 clonal variants, that the sensitivity might increase, but the specificity that tends to suffer a lot more. So there's a balance between sensitivity and specificity, and that's how we kind of arrived at the 16 clonal variants. And so once we kind of select the 16 clonal variants, we apply and design primers to it for a multiplex PCR, and then it undergoes next generation sequencing, and we at about 100,000 times depth, and then we produce a report. Next slide, please. Maybe I'll stop there and take any questions if there are any questions from the audience. Okay. And this is a simple report, so it's very easy to read. On the left-hand side, you can see that there's a presence and absence of ctDNA, so positive or negative. And then, of course, in clinical medicine, we observe trends in medicine. And so you can understand the kinetics of how patients are doing with ctDNA. And so you can see here that we report out in mean tumor molecules per milliliter. And it really accounts for the background noise for the cell-free DNA. And it also takes into account the circulating tumor DNA as well. And so with these patients, the real power of Signatera is the longitudinal monitoring for these kinetics. And as you can see here, this patient here started off with a positive test and then cleared their ctDNA to 0.00 mean tumor molecules per milliliter. Next slide. And the question is, what is our limit of detection? And we report out in VAF, which is called variant allele frequencies. And we're able to get down to a limit of detection of 0.01%. And this was a study that was done internally a couple years ago, but it really shows you that between the areas of 0.1% and 0.01%, there's about 40 to 50% of the variant allele frequencies that are harbored in that area. So if you're not able to get down to a variant allele frequency of 0.01%, you are missing about 40 to 50% of these variant allele frequencies. Next slide, please. And because we are tumor informed, we require tumor tissue. It's a one-time tumor tissue up front. And this is, of course, in a formalin-fixed paraffin embedded tumor block or in a form of slides. And if we're using a tumor block, it's going to be on average about 25 millimeters squared. But it's not necessarily about the size, it's about the tumor content. And the tumor content could be a minimum of 20%. So you can have a tumor block that's less than 25 millimeters squared and be submitted. Additionally, we can also use it in a form of slides. And usually we require about 6 to 10 slides of 10 microns each. Or if you double that, it would be 12 to 20 slides of 5 microns each. And there is also an additionally H&E slide that we require. And for the blood sample, in our kits, we provide EDTA tubes. The EDTA tubes function more of germline sequencing. And then we, of course, give the 2 Streck tubes, which are 2 10 mL tiger top tubes. And this is really serves as a normal control blood. So once the patient's assay has been designed, every time point after that is really just the Streck tubes. Next slide, please. And because we are tumor informed and a very personalized assay, we have been validated across the board. You can look here at high impact journals, colorectal cancer, breast cancer, lung cancer, bladder cancer. And of course, these are just the kind of the validation studies, but we are in all tumor types: pancreas cancer, sarcoma cancer, everything that you can possibly think of. But today's kind of focus is really going to be colorectal cancer and immunotherapy monitoring as well. And with our test, if you are positive, you have a 98% chance of going on to relapse. And that's our positive predictive value of 98%. And this is a very powerful tool, especially when with dealing with patients. This could become a big tool for oncology providers to be really helpful as an adjunct biomarker. Next slide, please. And kind of with that, I do want to introduce our next speaker. He is virtual. He is Dr. Gregory Boda. He is actually in San Diego, California, and it's probably around 8:30 or 9 o'clock his time. So with that, I do want to introduce, he is a medical oncologist by trade. He is a professor of medicine at the University of California, San Diego. He also has a lot of translational directorship roles, and his kind of wheelhouse is really in the GI space, but specifically pancreas. But maybe I will let him introduce himself. So with that being said, thank you, everyone. And, Dr. Boda, please take it on.
Thank you.
Grazie, Dr. Dane. Buonasera a tutti. Grazie per l'invito. I'm going to get started on our presentation today on some of the data analysis of SIGNATERA. I'm just waiting for the slides to appear. Excellent, thank you. So we'll go into some of the data analysis of molecular residual disease in solid tumors. Would like to start off with a case that commonly happens in my practice. Stage 2 colon cancer patient, 68-year-old, presented with lymph node negative T3 left-sided colon adenocarcinoma. Importantly, RAS mutant, BRAF wild type, microsatellite stable. This patient had some high-risk features, including lymphovascular invasion, perineural invasion. However, it was a low-grade, well-differentiated tumor, and like I stated, no lymph nodes of 30 were positive. The patient had no obstruction or perforation. This is a case that we commonly have in practice, where a patient might have some high-risk features, but the data does not say that we should necessarily treat them all. And this is where something like SIGNATERA could come into play. There are many different options for treating this patient. In some cases, we would observe this patient, not give them any additional adjuvant therapy. Some would give them maybe single-agent capecitabine for 6 months. Others may recommend capecitabine with oxaliplatin, similar to the IDEA trial. Something that I'd like to talk to you about is possibly using molecular residual disease, or ctDNA, to help determine the treatment paradigm for this patient. We all know that most of the patients that come to us with colon cancer, whether it's stage 1, stage 2, stage 3, about 80% of them are cured by resection alone. However, we don't know who those patients are. And therefore, many patients are given chemotherapy when in fact they don't necessarily need it and get the complications or effects from that. We do know that there are some patients without chemotherapy, they would recur and metastasize. And we need to give those high-risk patients chemotherapy to reduce their risk. The question is always, who are these patients? And we haven't necessarily been able to stratify them in the past. Could ctDNA help us do this? And that's where we're getting into the idea that ctDNA can be used as another tool, similar to CEA, similar to radiographic scans, similar to clinical features, another tool to help make these decisions. This is something that Dr. Dani had brought up, and I'll just get to the point is I'm using these in all of my practice settings. The SIGNATERA, of course, to look at the ctDNA, or the risk of residual disease, the risk of recurrence, and the availability of us to determine how our treatment's working, but also the ALTERA panel. The ALTERA panel giving me the actionable mutations. And in such way, I'm able to not only track recurrence, but I'm also able to get actionable mutations from that to make decisions with my patients. ctDNA is excellent for molecular residual disease, and we know that. Whereas we can grossly see disease on a patient, maybe in surgical practice, now getting to radiologic evaluation up to about 1/2 centimeter on imaging, now down to molecular DNA analysis of residual disease. And we're able to determine what is tumor DNA versus normal DNA. And that allows us to know the risk of every patient who has been treated either with surgery or chemotherapy. And in some cases, we're looking at now radiation and localized ablation techniques. Is there disease left in the body? How high risk is this patient? What other treatments do they need? How often should their surveillance be? And as I discussed, we're looking for high-risk patients. We're looking to detect relapse earlier, catch it before it metastasizes everywhere, catch it when it's only 1 or 2 lesions maybe in the liver, and then monitor our treatment, our chemotherapies, our immunotherapies, and in some cases, our targeted therapies. As was discussed earlier, the point of this test is in patients with known disease, to track their known disease. And importantly, in the post-surgical setting, we're able to determine if the surgery removed all of the disease or patients need adjuvant therapy. Now, very important, and something I'll bring up later, is that if you look at the green line, relapse, that's when imaging has shown that there's relapse. And we discussed that imaging shows relapse at about 1/2 of a centimeter. However, ctDNA can detect that relapse months earlier. And you're able to prepare our patients for additional treatment. You're able to use it as a monitoring device to maybe get them onto clinical trial. You're using it as a way to possibly image them earlier to track their disease over time. And then later, you're able to determine if your treatment is working or not and switch them to a different, more effective treatment earlier. This was something that Dr. Donnie had brought up. I won't belabor the point. But again, only at this point is looking at tumor-informed analysis. This is not a panel of genes where either patients have them or don't have them. This is a test designed for that patient's tumor specifically, so that when it tests for that patient's tumor in the blood, it has very high sensitivity. Again, the report that we're looking at and that our patients are looking at is whether or not that ctDNA goes down longitudinally or dynamically over time, but also that it goes to negative and stays negative over multiple tests. This is another area that Dr. Donnie brought up, but as we discussed earlier, ctDNA does not matter what the histology is. It matters if there's DNA in the tumor, and we know that all tumors harbor DNA, so it can be used longitudinally across all histologies. In addition, you can see the consistency of sensitivity across these histologies, where the separation of curves can be seen from anywhere. These are some areas that I will get into a little more depth, but what we've been able to do with this test in the last couple of years is predict treatment benefit. On the far left, you'll see that we're able to predict treatment benefit in bladder cancer with the use of immunotherapy. On the right, you'll see that we're able to predict the use of chemotherapy in colorectal cancer patients. But we're also able to predict those patients who won't benefit from chemo, and in fact will only be subjected to its harmful effects. Importantly, we're able to assess treatment response, and this is coming from the latest Circulate data from ASCO GI. We're able to show that patients who stay negative over time have an excellent disease-free survival of almost 100%. Those patients who are positive and then go to negative also have a very excellent outcome. However, those patients that are negative to positive or that remain positive after therapy have worse outcomes. On the right, you can see the patients who are given immunotherapy. And if they have ctDNA clearance, they have 100% overall survival at 3 years. And I'll get into a little more depth about these. Any questions about the foundation on this before I move into colorectal data? All right. The validation of this has done by Reinhardt et al. This was a paper in JAMA Oncology in 2019. And basically, they took stage 1 through 3 patients with colorectal cancer and assessed them by plasma samples up to 3 years to detect the recurrence rate and its association with the ctDNA in their bloodstream. And what we were able to find from this test is that with a single test, you were able to detect residual disease with high sensitivity and specificity. A negative test also provided you with great information that a patient would not relapse. Now, importantly, with serial sampling, the fact that you're consistently testing positive or you're consistently testing negative, or you switch from positive to negative or negative to positive, also gives you very important information about how a patient will do over time. And this is a key takeaway graph. I think it's very simple, but I think it really gets to the heart of it. On the left, you'll see Patients whose ctDNA that is positive after surgery will relapse 97 to 98% of the time. And if they're given adjuvant chemotherapy, we can reduce that by 27 to 30%. Now, as an oncologist, a medical oncologist, this was difficult for me to take my mind off of. Those surgical colleagues of ours, like Dr. Donnie, are doing a lot of the work. If you're able to remove that tumor and get their ctDNA to negative, the chance of recurrence is 12% with one test. However, if it's positive even after surgery and we give chemo, we're only reducing that by about 27 to 30%. And that does unfortunately fall in line with a lot of our studies in chemotherapy and decreasing relapse rate. Now, importantly, on the right graph, if you have multiple negative tests, you can get that relapse rate down to 3%. And many of our patients find great comfort in knowing that they only have a 3% chance of relapsing over the next 3 years, given the fact that their ctDNA is negative. Now, some other things that I want to take away is pathologically, there are high-risk features that drive our decision-making in giving patients chemotherapy. The mismatched repair status, MSI high, MSI low. The tumor grade, high grade, low grade, or the stage. Is it within the colon wall or is it perforated through the colon wall, T4? Those give us our hazard ratios or determining risk and if a patient should get chemotherapy or not. Now look at the SIGNATERA test, and because of its sensitivity and specificity, our hazard ratios are now at 7, 17, or even 43.5, meaning that the ctDNA gives us much better risk assessment of whether or not our patients need additional therapy or not. Any questions about the colorectal space before I move into immunotherapy? Immunotherapy obviously is being used to treat many tumor types and is starting to work its space and itself within the GI space. Importantly, with immunotherapy, there are some issues that we run into. Is a patient actually progressing or are they having pseudo-progression? Is the immunotherapy being effective or not? Are the side effects of the immunotherapy outweighing the benefits of the immunotherapy? And this is where ctDNA can come into play as a biomarker of immunotherapy efficacy. You can see that over time, we might get a CT scan number 1 that shows a small tumor burden, and we get our ctDNA analysis at that time. And basically, we start treating our patient with immunotherapy. At a certain time, we get another CT scan number 2. And that CT scan shows that the tumor has grown. And we're always left wondering, is this CT scan showing that the tumor is growing, or is this pseudoprogression? Is this just inflammation from the immunotherapy? And in fact, what we found is if the ctDNA is going down, that is meaning that it is being efficacious. And that CT scan is showing pseudoprogression. And we should continue giving the immunotherapy. Now, if later the ctDNA starts rising, we know that the immunotherapy is not being effective anymore. And in that case, we might move from regimen A to regimen B. And then now in regimen B, we're able to get a CT scan later that shows reduction of tumor size and ctDNA clearance. So this is a way in which the ctDNA can be used to evaluate or reveal what's really going on with the effectiveness of the immunotherapy better than a CT scan can. And in fact, this was evaluated by Bratman et al. In Nature Cancer 2 years ago, where they took patients of all tumor types, colorectal, melanoma, gynecologic, breast cancer, head and neck. And they treated them with pembrolizumab every 3 weeks, and they evaluated on CT scans and ctDNA. And importantly, what they found is that the ctDNA could be detected as early as 6 weeks to show effectiveness. So by the time you're getting onto your second dose of your pembrolizumab, you can already know if it's being efficacious or not. And we know that that's earlier than the CT scans. And we know that the patients whose ctDNA or tumor on CT scan did not shrink or actually increased, none achieved a response during the study. Importantly, those patients whose ctDNA cleared, went negative on immunotherapy, had a 100% overall survival over 3 years. Now, importantly, those patients whose ctDNA did not clear, did not go to negative, but decreased from its original starting point, did still provide benefit from the immunotherapy. And importantly, those patients whose ctDNA increased while on immunotherapy did not derive benefit from the immunotherapy and may have been a patient that you switched to a different treatment paradigm during that time. And again, you were able to determine that as early as 6 weeks. Any questions about immunotherapy data before I move into some of the predictive new data from some of the prospective studies? Okay. Currently, there is a large study going on called Circulate, and it is occurring in Japan and the United States, and of course, worldwide. And what we're evaluating are basically 3 separate trials in the colorectal cancer space. In one of the trials, the Galaxy study, it's a prospective registry study, observational study of patients with ctDNA being drawn across all different stages of colorectal cancer. In addition, there are 2 other trials that are created from that. There's the Vega trial, which is looking at a availability of reducing chemotherapy in patients whose post-operative ctDNA is negative. So they have their surgery, their ctDNA is negative. Do they need chemotherapy, or can we just observe them? Can we just watch them? And that's looking at Xeloda and oxaliplatin versus observation in patients who have negative ctDNA. On the other hand, are patients whose post-operative ctDNA was positive and completed adjuvant therapy, whether that's K-BOX or FOLFOX, and continue to have ctDNA positivity. Do they derive any benefit from additional chemotherapy after standard of care? The initial data for this came out at ASCO GI this past year here. And what we were able to find were a single time point after surgery in patients with stage 2 or stage 3 disease, the ctDNA being negative shows a very improved disease-free survival benefit at 6 months and at 12 months at over 90%. However, the patients whose ctDNA was positive at 4 weeks post-surgery, they had a disease-free recurrence rate of approximately 73%. And then at 12 months, that dropped to 55%, meaning that in a real-world scenario, the ctDNA is able to substratify the patients who are going to have relapse after their surgery and who would benefit from additional chemotherapeutics. Importantly, we needed to find out the patients that were negative, could we get any additional benefit from chemo with them? If they were going to relapse maybe 3% of the time or 10% of the time, can we lower that amount of relapse? And in fact, the patients who were MRD positive or ctDNA positive, if we gave them chemo, would they improve their outcomes? This was the predictive data. And in fact, we found that that was true. Patients with high-risk stage 2 disease, patients with stage 3 disease, and of course, patients with stage 4 disease, all benefited from adjuvant chemotherapy when their ctDNA was positive after surgery. And we can see that that green line shows that those patients who got chemotherapy after surgery had significantly improved disease-free survival. And it is of the absolute benefit we would expect, about 30% or so. Now, what about those patients whose ctDNA was negative? Could we push them and get additional 1 or 2% benefit from giving them chemotherapy? And in fact, we found that wasn't the case. These patients, whether you gave them chemotherapy or not, were going to end up the same way after their surgery, despite the chemotherapy. And these are the patients that we could avoid chemotherapy, avoid complications with. And that's where this test and the power of it comes in, the ability to substratify high-risk and low-risk patients. Importantly, what we're able to show, again, was treatment response. Those patients who stayed negative over time did excellent. Importantly, those patients who were positive and got adjuvant therapy, got chemotherapy after their surgery, they also did excellent. Now, those patients who were initially negative and turned positive didn't do as well. And of course, those patients who had constant positive ctDNA did the worst. Now, importantly, we are also able to show that this occurs in bladder cancer and, in fact, with immunotherapy. And the IM-Vigor study was able to look at patients who had invasive bladder cancer, whether or not they got immunotherapy or atezolizumab after their surgery. How did they perform? And this is very similar to the patients with colorectal cancer. The patients whose ctDNA was negative and got atezolizumab after their surgery, there was no significant difference between those two curves at the top. However, those patients with ctDNA positivity who got atezolizumab improved their disease-free survival, improved their overall survival compared to the patients who did not get atezolizumab. So patients who had bladder cancer had surgery for that. If their ctDNA was positive, they derived benefit from adjuvant immunotherapy. And if it was negative, there was not a significant impact in adjuvant immunotherapy. They would be able to avoid it. Now, if we go back to our original case study in that colorectal cancer patient, I hope I can reinvigorate your mind. And again, this is a 68-year-old patient, T3N0 disease, left side colon adenocarcinoma. KRAS mutant, BRAF wild type, some high-risk features, lymphovascular invasion, perineural invasion, but no lymph nodes positive. What do we do with this patient? And of course, we talked about some of the options, and truthfully, all of these are possible options you could have with your patient. But I hope that I convinced you that molecular residual disease could help you determine what to do with this patient. And in fact, in this case, we found that after surgery, this patient had a ctDNA that was positive. So we recommended Z-LOX for this patient. They got capecitabine and oxaliplatin, and their ctDNA went to negative after we gave that to them. We reduced the burden of disease. Then what we did is we followed them over time, and we found that actually their ctDNA turned positive around month 13th or month 14th after their surgery. And in fact, we eventually got a CT scan 3 months later that showed relapse. And the patient only had one specific liver lesion, so it wasn't diffusely metastatic. So what we were able to do was do local therapy to that liver lesion, radiofrequency ablation, and their ctDNA went back to negativity. We avoided repeat chemotherapy. We avoided a diffusely metastatic patient, and their ctDNA continues to be negative on follow-up. So this is the power of ctDNA. Finding a patient who we might have put on observation and giving them chemotherapy, reducing their disease-free survival, or increasing their disease-free survival, then using it as a surveillance tool to determine relapse earlier than a CT scan would be able to find, and then treat them in the oligometastatic setting, avoiding chemotherapy again later on. And this is how we're using it in our practice. Tumor-informed assays have high sensitivity, high specificity versus tumor-uninformed assays. There is obviously benefits and negatives to both, but understanding why you're ordering it and what information you're getting out of it is very important. At the end of the day, we're using this in 3 specific areas: stratifying high-risk, low-risk patients, detecting relapse earlier, do something about it earlier, and then monitoring a treatment response. Is my chemotherapy working? Is my immunotherapy working? Has my local therapy worked? Has my surgery worked? And thank you, everyone. Please let me know if you have any additional questions at this time, or we can open it for discussion.
Thank you very much
for your very interesting presentation. A few only. I want to make only a question to Michelino De Laurentiis, because I know that its time is very limited this afternoon. Michelino, pensi che dal punto di vista clinico nel tumore della mammella i risultati del test SIGNATERA siano utilizzabili già ora in clinica, o ritieni che sia necessario approfondire con valutazioni di efficacia più mirate? Michele De Laurentiis mi sa che è frizzato.
I answer in English, I guess.
Ok.
Well, data in the breast cancer scenario are more limited. However, they are very interesting, and I was wondering why there has been no such an investment in the clinical trial for breast cancer, at least to the best of my knowledge. What I found very interesting are the data post-neoadjuvant treatment. And I have a question. I was wondering whether we also have data post-surgery in, like in the colorectal cancer study that you showed us, just post-surgery in order to identify patients who need or who do not need chemotherapy, adjuvant chemotherapy. Do you have this data right now, or are you planning, or have you planned to generate this data?
Dr. Donnie, would you like to start with that?
I just want to clarify the question is, could you say it one more time? Sorry, I think the audio here was a little off.
So you didn't hear the question?
Yes, please.
Okay. So I was wondering whether you have data for breast cancer after surgery, because the data after neoadjuvant therapy are very interesting, as well as the data along the follow-up. But I was wondering if you have data like the one that you generated in colorectal cancer after surgery in order to understand which patients do need chemotherapy, adjuvant chemotherapy, or not.
Yes, thank you for clarifying. So in the breast cancer space, we do have a lot of ongoing collaboration, and it consists of either in the neoadjuvant space where we've found predictive data that if you are positive in the neoadjuvant space, it is predictive of outcomes for patients with, especially in context of path-CR. Post-surgically, we also do have data in that space, and also in the MRD surveillance setting. And so I'm happy to send it to you. I know we didn't go over it today, but I will tell you our journey in colorectal cancer is really far along. In fact, you know, United States, we're pushing the circulate data that Dr. Boda had showed us into NCCN guidelines, hopefully by the end of this year. Breast and bladder cancer are kind of right behind it. So while we don't have interventional studies just yet for breast cancer, we are actively searching for PIs to kind of conduct those studies with us. I'm not sure, hopefully that had answered your question.
Yes, of course, but I just have another one, if you can answer. I was wondering whether you can apply SIGNATERA to, you know, to core biopsy specimen in breast cancer. Do you have any indication that this is feasible? Do you have enough tissue to look at the baseline before surgery, ctDNA?
Yeah, so it's going to really depend on, I guess, what stage of disease, and then of course, if it's HER2 negative, triple negative breast cancer. But we do have data. Our baseline kind of varies, you know, between, I would say, about 70 to 95% with an internal data. But having said that, you know, we are still actively looking so for data in that space. But core needle biopsies we can absolutely do. Of course, larger the needle, you know, more passes the better, depending on who's doing it. But the one thing that we cannot accept at this point is an FNA biopsy. It's just far too minimum of tumor content for us to run it. I think in the research setting, we actually are able to do it, but in a commercial setting, it's just not something that's, you know, we're going to provide just yet.
Thank you.
Yes. This is an issue we've run into as we've tried to study some other GI tumor types like pancreas or biliary cancer that are commonly FNA'd or not biopsied. And we've had difficulty getting validation in those studies because of the sample size. What we've started to do at our program is talk to our proceduralists, our gastroenterologists, about acquiring larger tissue samples or more brushings so that we have more cells to send for a testing analysis. And this is a protocol we've set up at our institute.
That's interesting.
Thank you. Professor Pruneri, do you think that this approach may be useful from the pathologist point of view, is an additional information to your daily work.
Yes, thank you for the question, Paolo, and thank you for the presentation, for setting this very interesting meeting. Just let me ask. Of course, the answer is yes. The more the data and the better is the classification of the prognostic the parameters. But I mean, let me just ask you two questions. The first is more technical. Do you always need to couple the analysis of the tissue with the analysis of the blood in order to get the biomarkers? This is the first question.
Maybe I can answer that first. So yes, absolutely. I mean, we do need the tumor tissue in order to design. We don't have what's called a complete liquid biopsy form, just where it's basically just only from the blood. But I can tell you we are coming out with the end of this year. But as of right now, the SIGNATERA test is a tumor tissue, and then you match it to the normal control blood plasma.
And I can clarify, on additional tests, you do not need additional tumor. So once that test has been developed from the original tumor, every blood test after can be on its own.
Yes, this is for sure. But let me tell you that, of course, this could be a bottleneck, especially in some tumor settings. I'm just, wondering the rate of success you can have in biliopancreatic tumors. You know that in this case, the samples, the biopsy are very small, the tissue is very small in this. So this is, I think that, I would like to have a comment from your side about that.
It's a balance. Yeah, it's a balance, right? So tumor informed versus tumor naive tests. So pure liquid versus a tumor specific. There's positives and negatives to both. There are times, you're absolutely right, where you have insufficient tissue from an FNA or a pancreas. Or in some cases, when we use it with rectal patients who are going through either total neoadjuvant therapy, and we don't have enough tissue to send off. In those cases, then using a pure liquid biopsy or a pure liquid ctDNA may make sense. The issue, of course, is the sensitivity drops significantly by about 40%. So when that data comes back, you're kind of left sometimes, it's almost a flip of a coin whether or not it's negative or positive. Whereas with that tumor tissue, you're right, you have to set it up in an institute setting where your pathologists and your proceduralists all know how much tissue do we need from every biopsy to get this test if we're going to use it. I definitely understand where you're coming from, but of course there's positives and negatives to both. You're right, it could be a bottleneck if you don't have enough tissue, and that's where you have to have your institute and team on board to get that tissue.
And the second technical question is, you are performing a whole exome sequencing basically in the tissue. And what is the rate of detection of fusions and copy number variation? So it is enough deep the analysis? Because of course, as you know, in this case, we should use your analysis in order, of course, to get the procedure for the liquid biopsy then, but also for detecting all the biomarkers we need for treating the patient. So, the sensitivity for detecting, of course, mutation, but especially fusions is quite important.
Dr. Boda, would you like to answer that?
So you're absolutely right. On every patient that we order the ctDNA SIGNATERA test on, for every patient, I'm also ordering the ALTERA test as well. The ALTERA test is the actionable mutation test, very similar to Foundation 1, very similar to Tempus. So if you're doing whole exome sequencing, why not give the actionable mutations as well? So that's exactly what we're doing in our practice, is making sure we're getting both together. And we've talked, Dr. Donnie and I, eventually every company will do everything. But right now, that's not the case. But you're right. If you're doing whole exome sequencing, you might as well get your actionable mutation report. And that's what Natera can deliver.
No, you know, because there is a competition related to the tissue, of course, and also related to the reimbursement in a national health system like ours. And more in general, I mean, I'm very convinced, and you published very well your papers regarding the prognostic, you know, the prognostic relevance, of course, of this test. But probably Paolo and the oncologists and pathologists now, I mean, we like prognostic factors, but we are more, you know, interested at the moment in predictive factors. Can you comment on the new, you know, implementation of your test for the evaluation of predictive tests?
Yeah, so in our hands, I am using this information as patients come into the clinic and are being treated. With immunotherapy specifically, I'm evaluating if the ctDNA is diminishing or going away and continuing that immunotherapy. I have one patient actually who came to me with cholangiocarcinoma, MSI high, too many comorbidities for chemotherapy. So I put him on single agent pembrolizumab. His ctDNA went from positive to negative. He's been stable on that with almost a complete response for about 2 years. So that ctDNA dropped allowed me to determine that that immunotherapy was appropriate for him and that he could continue. As far as the patients who come through the door who have colorectal cancer, those patients, many times I'm using the ctDNA with these very fine decision making. T3N1 disease, do they need FOLFOX? Do they need CAPOX? These patients with T4N0 disease, should we give them Xeloda and oxaliplatin? Should we not? And as I showed before, that those types of pathologic markers, those hazard ratios, you know, are helpful. Of course, we've been using them for years, but the ctDNA hazard ratio is so high because of the specificity and sensitivity that we can use it to help manage our decisions. I specifically say everywhere I go, do not use ctDNA alone to make your medical decision making, but as a tool, it is very beneficial for your toolbox.
I completely agree with you, and thank you for your answer, and congratulations for the presentation. Very excellent. Thanks.
Thank you, Giancarlo. A question for Dani. Considering that the medical oncologist is the final user of this kind of test, can you explain in a very simple way the significance of ultra-deep scanning with respect, for example, to other methodology of circulating tumor DNA evaluation? Why why is it so important to restrict the number of mutations to evaluate with respect to other larger ways to evaluate circulating tumor DNA? Because I think that our colleagues, our clinician colleagues that are not so engaged in this area are not so sure that this is the so different way. It's a completely different way. I completely agree with you, but we need to explain better why.
Sure. So, you know, I think first and foremost, right, when we sequence the tumor, it does go under 100,000 times depth of sequencing, a red, but that is with the tumor tissue, and it's really stringent. And a lot of the companies out there are not getting to that level. Blood is a very different story, though, right? I think it's about half that's about 50,000 in terms of depth of red. But the idea that, you know, more is better is not necessarily the case here. In terms of clonal variants being picked up, there are other, you know, competitors, companies that may come out with a 56 gene clone assay, but we've found internally that throughout the histologies, that 16 is really the best way to maximize your sensitivity and specificity. And so in that case, more is not necessarily better. And you know, I don't know if Dr. Boda has any additional insights regarding that part of it. I know he's more of a PhD than I am in the genetic space, but hopefully that clarified your question.
Thank you.
Yes.
Ci sono domande dall'audience?
Sì. Chiedono se potete spiegare meglio la comparazione tra sequenziamento del tessuto e del campione di sangue.
They ask you which is the difference between the evaluation of tissue and the sample and the blood sample evaluation.
The difference, is it process oriented? Is that the question? What's the difference in the process?
In the process and in the clinical significance.
So so if you, with the tumor tissue, we're going to be identifying and undergoing whole exome sequencing, but the normal control blood is what.
Please slow.
Oh, sorry. When I get passionate, I talk faster.
But we are colleagues around all our nation.
Yeah. So with the tumor tissue, we use it to identify the clonal variants. The normal control blood is going to be undergoing the next gen sequencing. And we need both of them in order to come up with the assay. We can't just have the tumor tissue without the blood and vice versa. So we definitely need both tumor tissue and blood at the first or initial time point. Every other time point, it's just going to be normal plasma blood.
Thank you.
Paolo, chiedo scusa, io vi devo lasciare.
Grazie Michele, grazie infinite per essere stato con noi.
Very interesting discussion. Thank you very much. I'll be glad receiving further information about SIGNATERA. Thank you.
Thank you so much. Bye.
Sì, c'è un'ultima domanda. Quali sono le 16 mutazioni che identificate?
Which are the kind of the 16 mutations individualized, and why these 16 and not other?
Yeah, unfortunately, we do not report out on those variants. So we don't give out the report of which clonal variants we were detected. We just give out how many numbers, 16 out of 16 or 15 out of 16. I do know that we have an internal account of how much or what type of clonal variants, but with the commercial report, we unfortunately do not give the clonal variants out.
Thank you.
I have a question. My understanding is that the liquid biopsy is run by means of molecular PCR, and not by NGS. Is that right?
So from my understanding, there are actually companies out there with digital droplet PCR, not necessarily. We run it in multiplex PCR and next-gen sequencing.
Okay. Very interesting. Thank you so much.
Just a question. Have you any experience on the...
Only a moment, because we need a microphone.
Thank you. We know that it's possible in some cases if the tumor might be different when it's metastatic. And so you have any experience to re-challenge the tumor when he has an evolution instead of the original specimen?
Yeah. It's a good question. There's been some need from the providers to submit a second specimen as that tumor kind of evolves. We're not able to right now run it on dual specimens, which means essentially if you have a tumor tissue from a year ago and now it's been involved, we are not just, it's more of a kind of a technical issue that we're not able to run it, not a scientific issue. But having said that, because we're picking up 16 clonal variants, the idea is that we're going to be picking up those variants every single time, even in years ends of time. So to answer your question in a short answer, we're not able to provide that service just yet, but I don't think we absolutely need it just yet because we're able to pick up those and detect those 16 clonal variants.
And it's an important point to bring up is that the primary tumor will have the founder mutations, and those founder mutations will be found in the metastatic sites. Now, if you take a biopsy from a metastatic site, it may not have the founder mutations from the primary tumor. So I think that that's something that we've been dealing with as well in our practice to make sure we get that original tumor so that everything we test thereafter will be based on that initial founders.
Ci sono altre domande? No. Vuoi dire qualcosa in conclusione?
Yes. First of all, I thank you to everybody for joining this first meeting. It was very interesting, and I think that the question you asked were very useful to clarify some aspects that sometimes are not so easy to understand, no? Because this test is very new, and so sometimes we need to talk directly with the expert. So I think that it was a good occasion to increase our knowledge. And so thank you very much to everybody for your participation.
Thank you to all, and I am convinced that we start with SIGNATERA a new way in the minimal residual disease evaluation in solid tumors. Thanks a lot to stay with us, and good afternoon to all the people listening to us. Bye-bye.
Bye-bye.